medical workforce that comes from the tribal communities themselves to serve their own members. I look forward to hearing from Dr. Begich, who has been such a champion on issues regarding Indian health in Indian country. And with that, Mr. Chairman, I yield back.
Thank you, Representative Ledger-Fernandez. I will now recognize Mr. Begich for 5 minutes to speak on his legislation. Mr. Begich, if you're ready.
Thank you, Mr. Chairman. I'm proud to sponsor H.R. 3620, the Southcentral Foundation Land Transfer Act, and to bring before the subcommittee a bill that directly supports improved behavioral health care access for Alaska Natives in our largest city, Anchorage. This legislation represents a concrete, common-sense step forward in our commitment to tribal self-determination and culturally competent care. Southcentral Foundation is one of the most respected Alaska Native health care providers in the nation. It serves more than 70,000 Alaska Native and American Indian people through an award-winning model built on community ownership, integrated care, and cultural accountability. Their approach is innovative and effective. The facilities they use for delivering behavioral health services, like Keweenaw Clubhouse, are aging, inadequate, and in some cases repurposed from buildings never intended for clinical care. One of these buildings was literally a morgue. Patients who deserve dignity, safety, and modern medical infrastructure, and that's what this bill delivers. H.R. 3620 directs the Department of Health and Human Services to transfer title to a parcel of land in Anchorage that Southcentral Foundation already uses to deliver services. This will allow them to replace these outdated structures with a new state-of-the-art facility specifically designed for integrated mental and behavioral health care. The bill gives the foundation full legal title and the confidence to make long-term investments in care. This will enable smart local stewardship of health infrastructure. This bill isn't just about transferring federal property, it is about transforming lives. Southcentral Foundation's programs, including Keweenaw Clubhouse and intensive case management, are designed for individuals with serious, persistent mental illness. These are some of the most vulnerable members of our communities, and the work being done already is nothing short of life-changing. It's also about cost-effective governance. Alaska Native organizations like Southcentral have demonstrated that innovation in healthcare delivery can improve outcomes, deepen trust, and make the system more efficient. We should be encouraging that, not hampering it with bureaucratic red tape. In summary, H.R. 3620 is modest in scope, but powerful in impact. It's narrowly tailored, broadly supported, fiscally responsible. It's the right thing to do. It empowers a proven partner to expand services that are urgently needed and deeply valued in Alaska. I urge my colleagues on both sides of the aisle to support this bill. This is the kind of partnership-based, solution-oriented governance that our constituents expect from us. And I want to thank Ms. Leandra Ross for her testimony today and for the work Southcentral Foundation continues to do for the people of Alaska. And with that, Mr. Chairman, I yield back.
The gentleman yields back. At this time, I'll recognize Ms. Stansbury for 5 minutes to speak on her legislation. Ms. Stansbury.
All right, well, good morning, everyone. Thank you all for being with us this morning. Thank you, Mr. Chairman, and also what a delight to have our mini chairman here with us today. And thank you to our ranking member as well for having this hearing. It's always a joy to have New Mexicans in the house, and I want to say welcome to Miss Adrienne Begich, who's a doctor from Gallup, New Mexico, and also Mr. LaRoche, who's a South Dakotan, but also lived in New Mexico and is a UNM Lobo. We're excited to have you here. I'm here today to present our bill, the Indian Health Service Provider Expansion Act. This bill has been advocated across many administrations from within the IHS because it's a pipeline bill to get more doctors and healthcare practitioners within the IHS system to serve our tribal communities. In New Mexico, we have 23 sovereign tribal nations and a population that is nearly 12% of the overall population of the state, and access to healthcare is a pressing issue not only in our tribal communities but across the entire state. Currently, the IHS provides services in 37 states and to over 2 million people. And the IHS has more than 1,330 vacancies for healthcare professionals, and certainly the efforts by DOGE to conduct mass firings and retirements haven't helped that at all. This includes physicians, dentists, nurses, pharmacists, physician's assistants, and nurse practitioners. And the impact of inadequate, understaffed, and underfunded healthcare on both the physical and mental well-being of Indigenous communities is pronounced, with far-reaching consequences not only for quality of life, but for well-being and, of course, health outcomes. Insufficient access to timely and effective medical interventions and healthcare results in prolonged pain, discomfort, and compromised physical health. The IHS Provider Expansion Act is a vital step towards ensuring that our Indigenous communities can access healthcare and grow the number of medical professionals serving in Native communities, including Native doctors and practitioners themselves. By investing in medical education within IHS, we can help to expand healthcare and bridge the gap in disparities that have persisted for generations. This bill is projected to directly impact millions of people across the country served by IHS and to improve access to healthcare and medical professionals who understand the unique health challenges faced by tribal communities and also in providing culturally attentive care. By expanding access through IHS, this bill will also help to address significant deficiencies in primary health care, especially in rural communities. It would create a mechanism for future healthcare professionals and paraprofessionals and other healthcare-related professions to participate in residency opportunities and fellowship opportunities in hospitals and clinics across Indian country. The office would also oversee and serve as a hub and consult and coordinate with academic institutions, with tribal nations, and on current residency and fellowship programs at IHS facilities. This office would also work with academic institutions to help pipeline medical students and provide rotational and educational programs in IHS facilities. This is a critical bill to help expanding the availability of healthcare. I want to end by saying that our sovereign tribal nations are proud. Healthcare is not only a moral responsibility of the federal government, it's a legal responsibility under trust and treaty responsibilities. And that is why the IHS exists. The history of trauma and violence that has impacted Indigenous communities continues to affect both health outcomes and mental health needs in communities, and of course affects the availability of healthcare. It is a fundamental responsibility of the United States to not only address the deficiencies in IHS healthcare, but to work hand in hand with our tribal nations to ensure the health, the well-being, and the thriving of all communities across the country. And with that, I yield back.
The gentlewoman yields back. At this time, I'm going to introduce the witness for our first panel, Mr. Darrell LaRoche. Mr. LaRoche is the Acting Deputy Director of Indian Health Service, Department of Health and Human Services in Washington, D.C. Welcome, Mr. LaRoche. At this time, I'd just remind you that under committee rules, we would ask that you please limit your oral statements to 5 minutes, but your entire statement will appear on the hearing record. I know you said this is the first time testifying, but it's not too difficult. But to begin your testimony, just press the talk button on the microphone. We do use timing lights here. When you begin, the light turns green. That means go. When you have 1 minute left, the light will turn yellow. And at the end of 5 minutes, the light will turn red, and I would ask you to please complete your statement. And I will also be allowing all witnesses in this panel and in our second panel to testify before member questioning. So, Mr. LaRoche, at this time, I will recognize you for 5 minutes.
Good morning, Chairman Hurd and Ranking Member Ledger-Fernandez and the members of this subcommittee. Thank you for the opportunity to testify on H.R. 3620, the Southcentral Foundation Land Transfer Act, and H.R. 3670, the Indian Health Service Provider Expansion Act. The Indian Health Service is an agency within the Department of Health and Human Services, and I want to reiterate our mission, which is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. This mission is carried out in partnership with tribal communities through a network of over 600 federal and tribal health facilities in 41 urban Indian organizations located across 37 states, providing health care to approximately 2.8 million American Indians and Alaska Native people annually. And the IHS is the 18th largest healthcare system in the United States. H.R. 3620, the Southcentral Foundation Land Transfer Act, would direct the Secretary of the Health and Human Services to convey certain land in Anchorage, Alaska to the Southcentral Foundation by warranty deed. The bill would require completing the conveyance as soon as practicable, but no later than 2 years from enactment. The bill would free Southcentral Foundation of any liabilities that it would otherwise have assumed for any environmental contamination that may have occurred on or before the date of transfer, except the Secretary would not be liable for any contamination that occurred after the date that the Southcentral Foundation controlled, occupied, and used the property. We have seen similar bills of this sort move through Congress in previous years, mandating transfer by warranty deed rather than by quitclaim deed. As with those previous similar bills, the department has some concerns with this bill. In particular, the bill describes the use of conveyance to be for healthcare purposes, but does not specify the actual health programs in service to American Indians and Alaska Natives. Thus, the conveyance of the property under the bill does not guarantee health services specifically for AIAN population. Also, the bill would bar retention of reversionary interest and thus deprives the department of a means to ensure the property will return to the department ownership if at any time the property ceases to be used for the provision of health services for the purposes of this bill. Simply stated, the department prefers to avoid transfers by warranty deed, as such deeds create the potential for liability if a competing priority interest or property interest is subsequently discovered. Therefore, we welcome the opportunity to work with the subcommittee and the drafters on this bill on prospective amendments outlined in our written testimony. Now for H.R. 3670, the Indian Health Service Provider Expansion Act. This bill would amend the Indian Healthcare Improvement Act to establish an Office of Graduate Medical Education Programs in the IHS. This bill would create a mechanism for the future healthcare professionals mentioned in this bill to participate in residency and fellowship programs, and the office would oversee, serve as a hub, and consult and coordinate with academic institutions on current residency and fellowship programs at IHS facilities. In furtherance of this office, the Secretary would work with other HHS agencies and other departments to create an interagency work group to assist in the development of this office and its plans for long-term stability. On a final note, we think it's important to inform this committee that in IHS, as Representative Stansbury mentioned, there are 1,300 vacancies for healthcare providers, and the vacancy rate of our IHS primary positions, such as physicians, physician's assistants, nurses, and dentists, is averaging 33% vacancy rate. To close, we look forward to our continuing work with Congress on these bills and welcome the opportunity to provide any technical assistance as requested by this committee or members on both bills. I'm happy to answer any of your questions the subcommittee may have.
Thank you, Ms. LaRoche, for your testimony. The chair will now recognize members for 5 minutes for questions, and I'm going to begin by recognizing myself for 5 minutes. Mr. LaRoche, thank you very much for what you shared with us this morning in your written and as well as your oral testimony. With respect to H.R. 3620, my understanding is that the land in question was previously used to house staff from the Centers for Disease Control. But since the 1990s, the land was used by SCF to house the Keweenaw Clubhouse, even though it still is owned by the department. Do you know at what time the department purchased the land?
I do not have that in front of me right now.
Okay. I know you expressed some, maybe that's something we could follow up with afterwards. If you could provide that information to us, that would be great. I understand the concern that you expressed about the property transfers here, but you mentioned that Congress has authorized similar property transfers in the past, correct?
That's correct.
And would it be fair to say that HHS has been successfully able to implement those directives?
That's correct.
Okay. Talk to me a little about the warranty deed, quitclaim deed issue. Explain that concern to me and also how that's played out in the past.
Sure, thank you for that question. So the warranty deed has no reversionary clauses in it and provides a clear title guarantee. And the quitclaim is actually something that the department's used to transferring land using that mechanism. And it includes the reversionary clauses, and it's consistent with our Indian Self-Determination and Education Assistance Act.
So one of the things back, putting my old lawyer hat on, my understanding of how warranty deeds typically work is there's a warranty of ownership or of title that you're transferring when you transfer the property, whereas a quitclaim deed is simply, I'm not sure what I have, I'm just giving you whatever it is that we may or may not have. One of the concerns that I might have, at least back in my real estate law days, was that a quitclaim deed might make it harder for the recipient of that quitclaim deed to be able to use the land or to get financing arranged for things like that. Is that something that is a fair concern to have in this situation, or is a quitclaim deed, would that be adequate here?
I think with the quitclaim deed, it allows for us, if specifically the land is to be used for Alaska Native and American Indian services, and if at any time there's a different use of it, it would allow us to be able to take that back, as well as if there was any trying to think if the program had to come back to us, which is highly unlikely.
Okay, got it. I want to switch gears to HR 3670, which authorizes $4 million annually to start up an Office of Graduate Medical Education within IHS. Does the department have an estimate of the actual cost required to launch and sustain a fully functional graduate medical education program?
We have the $4 million that's mentioned in this bill.
Do you know if that's sufficient or close to sufficient?
We'd be happy to take that for technical assistance on that.
Okay.
Answer any questions.
Okay. Do you know how the $4 million number was reached?
I do not.
You don't?
But
okay.
we can.
Mr. Chairman, if you'd yield, I can answer that question.
I think I have no further questions, so thank you very much, Mr. LaRoche. I appreciate that. At this time, I will recognize the ranking member for 5 minutes of questioning. So, Ranking Member Ledger-Fernandez.
Thank you very much, Mr. Chair. Deputy Director LaRoche, as I mentioned in my opening statement, I was very saddened to read that the proposed budget eliminated advance appropriations for the IHS. Now, you're aware that it took us quite a while, and we had been advocating for advance appropriations for years, because that is similar to what the VA gets, for example. Can you tell us why advance appropriations is important?
I would end up having to go back to our hearing that we had last week with the Budget Committee on that for questions. Sorry.
So you don't know why advance appropriations are important to continue funding healthcare in Indian country? I guess, do you support eliminating advance appropriations?
The Indian Health Service remains committed to carrying out whatever the law is for appropriations.
But right now, the budget request the Trump administration proposes eliminating advance appropriation. Do you think it is fair to eliminate advance appropriations for the Indian Health Service when you keep it for the VA?
I wouldn't be able to comment on that. Apologies, I came prepared for the two bills that were being presented here.
So, well, let me ask another question. You are aware that there are shortages of providers in IHS clinics. In fact, your testimony, in terms of what you're prepared for, notes that they are severely understaffed. In fact, if each facility across the IHS lost just one physician-level provider, 43% of those facilities would have to close their doors completely. Now, the fact that they are understaffed is in your written testimony, so hopefully you are prepared to talk about this. How is it that, given that level of understaffing, there is continued forcing out and elimination of IHS employees? Don't you think that's going to hurt the ability of IHS to provide the services that are required in Indian country?
We have been fortunate that we've had waivers for our medical staff that are actually providing services in the field.
So if I recall, last time I went to a doctor and last time I visit, before I got to Congress, I helped build health clinics in Indian country. It takes more than sitting in a room with the doctor or the provider. There are a lot of people who get you into that room. And I think that the continued cuts to IHS are very difficult. Now, I take it you have visited 638 or compacted facilities?
Yes.
And I take it you are aware that those facilities rely on Medicaid funding to provide their enhanced services to their members?
Yes.
So let's see if you'll answer this. Do you agree with the testimony we received at our hearing in Oklahoma that Medicaid cuts, as proposed by the Republicans, would be devastating to those facilities?
I would have to go back to that testimony and read that. Sorry.
Okay, but do you basically understand this? When you eliminate, maybe you will put it this way, we know that in Indian country, there is $4,078 provided per patient. You compare that to $13,493 provided per patient in the U.S. health system. It's really sad that we provide it at such a low level. But would you agree that any cuts, when you already have such low-level funding, to the ability to provide medical care would hurt the provision of medical care?
Apologies, I'm not prepared to comment on that.
Okay. So, I mean, that's our problem, is we're getting administration witnesses here who are unwilling to speak about areas that they have jurisdiction over. And I think that this shows that we are seeing cuts that the Trump administration is doing, and those cuts are having and going to have devastating effects. That is the testimony of our tribal leaders. And perhaps those cuts are coming from outside of the agency itself, outside of the people who have the expertise, and then those who have the expertise are muzzled. I feel for you, Deputy Director LaRoche, and with that, I will yield back.
Ranking member's time has expired. The chair now recognizes the gentleman from Alaska, Mr. Begich, for 5 minutes of questions. Mr. Begich.
Thank you, Mr. Chair. Mr. LaRoche, Your testimony states that the bill does not explicitly tie the land transfer to services exclusively for Alaska Natives, raising concerns that the property could be used more broadly. The Southcentral Foundation, however, is a tribally operated 638 contractor that already serves over 70,000 Alaskan Native patients and has successfully operated healthcare programs on this particular property for 3 decades. Given that, does HHS have any specific reason to suppose that they intend to shift away from those services? And is HHS aware of any specific scenarios that SCF might be contemplating now that would justify a federal reversion clause?
I would say that that was highly unlikely.
Okay. Another question. The bill contains a provision to protect Southcentral Foundation from liability to any pre-existing environmental contamination. Does HHS have any reason to believe there is existing environmental contamination on the property?
It's my understanding from our staff in Alaska that that property has cleared the environmental assessments and so forth. So.
Okay, very good. And lastly, in your testimony, you expressed some concern about conveying land by warranty deed rather than under the Indian Self-Determination and Education Assistance Act. Yet Congress has passed several such bills in the past. In this case, Southcentral Foundation has an exceptional track record. Does HHS have any specific concerns about transferring the land in this way to SCF in particular, or are these just general concerns?
We're actually able to and have done so in the past by either one.
Okay, thank you very much. I have no further questions, and I yield back.
Gentleman yields back. At this time, the chair recognizes the gentlewoman from New Mexico, Ms. Stansbury, for 5 minutes. Ms. Stansbury.
All right, thank you, Mr. Chairman. I do want to just address the question that you asked the witness a few moments ago. This is a bipartisan bill that we've worked on for a long time with not only the last administration, but it's been ongoing for many years. And the $4 million request was actually a request that came through the president's budget in past years. So it's an internal recommendation from the Indian Health Service through their budget process. So just wanted to make sure you knew that where that came from. We didn't make it up. It came from the agency. All right, Mr. LaRoche, thank you so much for being here today. I was reading your bio a little more closely, and also interestingly, I didn't realize that you are a facilities manager and did the civil engineering program at UNM. My partner did as well. So a funny irony, and he has some South Dakota ties as well. So it's serendipitous that you're here today. But the part that kind of caught my eye here is that you also worked in the public health service and that you've been at IHS for 20 years and are an SES person. So you're a career staffer who has stuck around and are here duly doing your job defending the Indian Health Service. And so I want to give you a moment to take a little bit of thanks and gratitude for staying and for, I know it's a very hard time right now for our federal service, and it's especially important that longtime managers who care about our agencies and care about the people of our agencies stick around. And so I'm genuinely thankful that you're there. I'm getting emotional thinking about it. It's been a hard 5 or 6 months, especially for folks who are serving Indian country. And it's ironic, Mr. Chairman, because literally I got a phone call this morning as I was heading into this hearing, which is why I was a few minutes late, from a tribal leader in New Mexico, because we actually have a tribal leaders conference every year between our governor and the tribal leaders of our state to do state consultation. And the issue that came up that our tribal leaders are highly alarmed about this tax package is particularly the cuts to Medicaid and to food assistance. And so I know, Mr. LaRoche, you're not here to answer for anyone, but I wonder just factually if you could help us understand the role that Medicaid plays in helping to supplement IHS services. Just like how does the billing for Medicaid, do you have a sense of how many individual clients of IHS are also on Medicaid?
We do use Medicaid to supplement our funding, and I'd have to ask my staff or take that back for any more details on that.
But would you say it's fair to say that a significant number of patients and clients of IHS are also Medicaid recipients and Medicare recipients?
It's a source, definitely.
Yes. And certainly, IHS not only runs its own clinics, but also provides funding that is contracted out by tribes who also run clinics, as well as provides funding for nonprofit and other unaffiliated organizations. And what I can tell you is certainly in New Mexico, without Medicaid, the entire system collapses. I mean, whether it's hospitals, clinics, nonprofit organizations, it's Medicaid, it's IHS, it's some private insurance, but all of these sources make the very meager healthcare that is available actually work. And that's why tribal leaders are really sounding the alarm on these cuts to Medicaid, because they will have devastating impacts to access to healthcare. Now, that's not the topic, obviously, for this hearing, but I wonder if in the remaining minute or so, Mr. LaRoche, you could talk about the importance of recruiting and retaining more healthcare professionals to IHS and why that's so important.
Thank you for that question. Yes, definitely our workforce and the recruiting and retention is important, and the tool that this bill allows us to do is actually begin a pipeline for bringing those providers out of medical school into our system. And we have found that if you have done residencies and so forth in rural communities and with the tribal communities, they tend to stay there.
Yeah, absolutely. And one of the programs that we're really proud of at UNM is actually a cohort program in addition to some of the fellowships that are associated with this bill. When you go through medical school or healthcare training programs, you kind of end up in the rat race of it all and trying to figure out how to get a residency at, the most prestigious place. But one of the things that's really important is that we have high need communities, but also a lot of people go into healthcare because they want to go home and serve their community, but there's not an obvious pipeline to get them there. And so that's why this program is so important. And I thank you, Mr. Chairman, for creating an opportunity for it to be heard. Thank you. I yield back.
Gentlewoman yields back. I want to thank you, Mr. LaRoche, for your testimony and also our members for their questions. We may have some additional questions for you as a witness, and we ask that you respond to those in writing. At this time, I would ask the clerk to please reset the table. And while that's happening, I think we can introduce our witnesses for our second panel.
Mr. Begich and Ms. Stansbury.
I need to bring my glasses next time.
Oh, we had to change the order because of the wheelchair.
So it looks like Begich is on the left, right? Okay, it looks like our witnesses for our second panel are set up. At this time, I'm going to introduce each of you, or we may have some introductions to be made for you, but I'm going to start with the Honorable Beverly Cook, Tribal Chief of the St. Regis Mohawk Tribe of Akwesasne, in New York. Welcome. Next is the Honorable Robert Curtis, who is President of the Keweenaw Bay Indian Community in Bergman, Michigan. President Curtis, it's nice to have you here. The chair now recognizes Ms. Stansbury from New Mexico for 30 seconds to introduce the witness from her district. Ms. Stansbury.
Thank you, Mr. Chairman. I am so honored and so pleased to introduce our witness today, Dr. Adrienne Begich. Dr. Begich is the Navajo Nation Senior Advisor with the HEAL Initiative under the Division of Hospital Medicine. She completed her undergraduate studies at University of Arizona and received a medical degree from University of North Dakota School of Medicine through the Indians into Medicine program. She completed her residency in family medicine at the University of Arizona and is a diplomat of the American Board of Family Practice. She leads the HEAL's strategic plan goals of expanding additional sites in addition to Navajo Nation and designs and builds pathways for Native American health workers as they work with underserved communities in both the Navajo Nation and across the United States. She also serves as a beloved mentor to many fellows based in the Navajo Nation, and we're really honored, especially after her harrowing trip to get here today to testify. Thank you so much.
Thank you, Ms. Stansbury. The chair now recognizes Mr. Begich for 30 seconds to introduce the witness from his district. Mr. Begich.
Thank you, Mr. Chairman. I'd like to welcome Ms. Leandra Ross, Vice President of Executive and Tribal Services at Southcentral Foundation in Anchorage. As a tribal member and healthcare leader, Ms. Ross represents one of Alaska's most effective Native-run health systems, one that's improved outcomes through self-determination and innovation. H.R. 3620 supports that work by transferring federal land to expand behavioral health services in Anchorage. Ms. Ross, thank you for your leadership and for sharing your insights with us today. Thank you as well for making that very long trip from Anchorage to our nation's capital. We're looking forward to hearing from you. And I yield back.
Thank you very much, Mr. Begich. Let me remind the witnesses that under committee rules, they must limit their oral statements to 5 minutes, but your entire statements will appear in the hearing record. To begin your testimony, please press the talk button that's in front of you on the microphone. We do use timing lights. As I mentioned before, when you begin, the light's going to turn green. When you have 1 minute left, the light will turn yellow, and at the end of 5 minutes, the light will turn red, and I would ask at that time that you please complete your statement. I will also allow all of our witnesses on the panel to testify before member questioning. The chair will now recognize the Honorable Robert Curtis for 5 minutes. President Curtis.
Good morning. Good morning. Chairman Hurd, Ranking Member Ledger Fernandez, and the honorable members of the subcommittee. My name is Robert R.D. Curtis, Jr. I am the president of the Keweenaw Bay Indian Community. Thank you for holding this hearing on H.R. 411, the Keweenaw Bay Indian Community Land Claim Settlement Act. This bill would compensate our tribe for the unconstitutional taking of our treaty-protected reservation lands and confirm title for the current landowners. Before I begin, I want to thank Congressman Bergman for being a champion of our tribe's cause. I also want to acknowledge our tribe's vice president behind me, Everett Echdal Jr., who serves on our tribal police department, protecting our community, as well as my fellow tribal council members that have traveled with me from the Upper Peninsula to carry our message. I appreciate their strength and support. Migs. Today, the Keweenaw Bay Indian Community is located on the L'Anse Indian Reservation in Berga County on the shores of Lake Superior's Keweenaw Peninsula. In the mid-1800s, the western frontier continued to expand, and the federal government took a greater interest in the mineral resources of the Upper Peninsula. This led the United States to enter the 1842 and 1854 treaties of La Pointe with our ancestors. Through the 1842 and 1854 treaties, we ceded lands in Michigan and Wisconsin in return for constitutionally protected and permanent reservation, the L'Anse Indian Reservation. Unfortunately, the promises made in these treaties were not kept. Despite the protections of the 1842 and 1854 treaties, our reservation lands were unlawfully seized and transferred to the state of Michigan through the 1850 Swamp Land Act and the 1852 Canal Land Act. Shortly after the signing of the 1854 treaty, the state of Michigan began demanding that the federal government transfer title to wetlands within our reservation based on the Swamp Land Act. For many years, the federal government flatly rejected Michigan's contentions, and the United States General Land Office refused to transfer title because it would have been illegal. The Interior Department informed Michigan that its submission of the swamplands list did not obligate the U.S. to transfer these lands because they were already reserved for our people. The Supreme Court confirmed this in 1906. However, the General Land Office transferred 2,700 acres of reservation swamplands to the state of Michigan between 1893 and 1937. These transfers violated both federal law and the creation of a reservation through the 1854 treaty. The community has never been compensated for this unlawful taking. Further, through the Canal Land Act, the community lost more than 1,300 acres of our reservation. The Canal Land Act was intended to help finance the construction of the Sault Ste. Marie Canal. The United States granted Michigan the right to select 750,000 acres of federal land within the state to help pay for construction of the canal. The state selected more than 1,300 acres within our reservation. The Secretary of Interior approved Michigan's land selection within our reservation, even though those lands were already constitutionally protected property under the 1854 treaty. Our tribal council sought to advance these claims and the justice our tribe is due through non-adversarial means so that we could maintain harmony with our neighbors. The community presented documents related to the Fifth Amendment violation claim, and in December 2021, the Interior Department stated that, and I quote, "We have carefully reviewed pertinent documents, including the tribe's expert reports, and have determined that the tribe's claims to the swamplands and canal lands have merit. To resolve these longstanding claims, the tribe has worked closely with our neighboring communities, the state of Michigan, the federal government, our congressional delegation. Our efforts resulted in this bill, which ensures that our neighbors are not harmed, the community is made whole, and harmony amongst our collective communities is preserved. This bipartisan bill is supported by our non-Indian neighbors, Berga County, the village of Berga, and the village of Lawrence, as well as the governor of Michigan. Our bill also passed the Senate by unanimous consent last Congress. Enactment of the KBIC Settlement Act would mean that KBIC is finally compensated for the taking of our lands. Our neighbors would gain clear title to their land, and the state and federal government would right a historical wrong. Thanks again for holding this hearing. I would be happy to answer any questions.
Thank you, President Curtis, for your testimony. The chair now recognizes the Honorable Beverly Cook for 5 minutes. Chief Cook.
My name is Beverly Cook, one of the 3 elected chiefs of the St. Regis Mohawk tribe. We are the federally recognized tribe governing Mohawk territory in northern New York. Thank you both, the subcommittee, for this opportunity to testify in support of H.R. 2916 and to Representative Stefanik for introducing the bill. The bill would ratify and confirm the agreement of settlement and compromise to resolve the Akwesasne Mohawk land claim in the state of New York. Confirming the settlement agreement would end a long-standing dispute as to lands within the Mohawk Reservation to the satisfaction of the St. Regis Mohawk Tribe, the Mohawk Council of Akwesasne, the State of New York, the New York Power Authority, Franklin and St. Lawrence Counties, New York, and towns within the counties. The Mohawk land claim has a long history. From time immemorial, the Akwesasne Mohawks occupied territory in what is now northern New York and southern Ontario and Quebec. The 1796 treaty with the 7 nations of Canada, ratified by the U.S. Senate, reserved tracts of land in New York State to the Akwesasne Mohawks. Contrary to the Federal Non-Intercourse Act, the state of New York took title to these reserved lands. In 1982, the Council of Akwesasne filed a lawsuit against the state of New York, municipal governments, and private landowners. This lawsuit was seeking title to the lands reserved in the 1796 treaty. In 1989, the St. Regis Mohawk Tribe and the Mohawk Nation Council of Chiefs filed a separate lawsuit for the same claims. The suits were consolidated, and in 1998, the United States intervened as a plaintiff. The parties reached a potential settlement in 2005. In that same year, the U.S. Supreme Court decided the case of City of Sherrill versus Oneida Nation of New York, which was read as creating a new defense called Cheryl Latches for Indian land claims. Defendants then refused the settlement agreement and filed motions to dismiss the land claim. In 2013, the court did dismiss some of the claims based on Cheryl Latches. They also denied some claims, ruling that because the Mohawk people had not left the area, it was not subject to the defense. After that ruling, settlement negotiations began again among the tribe, the state, the New York Power Authority, and St. Lawrence County, resulting in a 2014 Memorandum of Understanding. Negotiations later expanded to include Franklin County, the Mohawk Council of Akwesasne, and the Mohawk Nation Council of Chiefs. After years of negotiation, including 2.5 years of court-supervised mediation, the parties agreed to final language for the settlement agreement in late 2024. All parties to the settlement agreement approved it, except the Mohawk Nation Council of Chiefs, which decided to withdraw from the case. The other parties agreed to the withdrawal. The withdrawal does not stand in the way of a full and final settlement of the claims in the case. The settlement agreement is to the benefit of all parties to the case and all stakeholders in the region. 1, the settlement legislation would ratify the transfer of all lands that were the subject to the lawsuit. 2, no landowner would lose land to the tribe. Any lands that become tribal land would be by free and voluntary transfer. The settlement agreement clarifies jurisdiction within the land claim areas. It provides the manner in which the lands within certain areas of Franklin and St. Lawrence counties that are owned by the tribe would become Indian country, free of state and local taxation and jurisdiction. It further provides that lands within these areas that are not owned by the tribe would continue to be subject to state and local jurisdiction. The settlement agreement provides that back property taxes on Mohawk-owned lands within the counties will be paid by the state to the counties, benefiting the counties and the Mohawk owners. Going forward, individual Mohawk landowners will continue to be subject to county property tax unless they deed the property to the tribe if they are in one of the designated settlement areas. The New York Power Authority would pay the Akwesasne Mohawks $2 million per year for 35 years. It would also offer 9 megawatts of power to the Akwesasne Mohawks at preferred rates. The New York State will waive tuition and mandatory fees for Mohawks in SUNY colleges. It is worth noting that the settlement will cost the federal government nothing, as no payments by the federal government are involved. Thank you for the opportunity to testify before you on this bill of great importance to the St. Regis Mohawk tribe. We look forward to working with you toward the passage of this vital legislation.
Thank you, Chief Cook, for your testimony. The chair now recognizes Dr. Adrienne Begich for 5 minutes. Dr. Begich.
Good morning, Chair Westerman, Chair Hurd, Ranking Member Ledger Fernandez, and members of the subcommittee. Thank you for this opportunity to testify in support of H.R. 3670, the IHS Provider Expansion Act. Adrienne Begich yun siat kapahin ni basishin katnizat ni dashiche dot ashtia dashanala. I am Edge of the Water Clan, born on the Navajo Reservation and raised by a hardworking single mother. While raising 3 children, completed my undergraduate degree, completed my medical school training, and also completed residency. After completion of my education, I started with the Indian Health Service, and I served initially with the Salt River Pima Maricopa community in Arizona, and then returned to serve my own people at Gallup Indian Medical Center until my federal retirement. Today, I serve as a senior advisor for the University of California San Francisco Heal Initiative's Fellowship, where I empower Native professionals in healthcare leadership. Throughout my career, I have worked alongside incredible people who go above and beyond to serve their communities. Despite their commitment, we face a health workforce shortage. With more than 80 million Americans living in areas with too few healthcare providers, many of these areas are rural and in tribal communities. These shortages are even more severe. up to 33%, but in some areas of the country, 46% of physician positions in some IHS regions are unfilled. On the Navajo Nation, this staffing crisis combined with long distances, sometimes 100 miles across unpaved roads, can literally mean the difference between life and death. Delayed diagnosis, missed appointments, and shuttering of essential services lead to worse healthcare outcomes. Provider burnout only exacerbates the crisis. We know that where doctors train is a strong predictor of where they will eventually work. As one national study found that residents who spend a majority of their training in rural areas were 5 times more likely to continue practicing in those same areas. However, out of the $25 billion spent on graduate medical education in the U.S. annually, IHS receives no direct funding to train residents or fellows. This means that out of the 145,000 medical residents nationwide, just 77 train full-time at IHS, tribal or urban Indian sites. That's only 0.05%. Despite these challenges, 8 residency and 5 fellowship programs operate at ITU facilities, and they work. In 4 tribal family medicine residencies, 51% of graduates stayed in the ITU system, and in the 3 Oklahoma tribal residency programs, 72% practiced in rural areas after finishing their training. At the UCSF HEAL initiative, we've seen similar results. Our fellowship pairs U.S.-trained doctors with local site fellows at 19 locations, including Navajo Nation. Of the 37 doctors who served during their fellowship, 11 stayed long-term. That's what's possible when you invest in training rooted in community and culture. These programs can also save money, as it is possible to bring in multiple residents and fellows for the cost of one temporary contract provider like a locum tenens physician. Investing in GME means investing in people who build trust and stay. HR 3670, the IHS Provider Expansion Act, is necessary because it establishes an Office of Graduate Medical Education within IHS, finally giving the agency the authority and the resources to coordinate, fund, and grow these crucial GME opportunities. It's modeled after the Veterans Health Administration's Office of Academic Affiliations, which has successfully partnered with teaching hospitals for over 75 years. Today, the VA's GME budget supports 75,000 trainees and nearly 12,000 residency positions. It's time Indian country also has the opportunity to grow its workforce. As a teenager, I shadowed Dr. Taylor McKenzie, our first Navajo physician. He showed me that someone born on the reservation, just like me, could become a doctor. That experience shaped my lifelong commitment to empowering American Indians, Alaska Native students who want to return home and care for those communities, and this legislation builds on that system. By expanding and coordinating medical education ITU sites, we can improve, expand access, and build a health workforce that reflects and serves our people. Thank you again for the opportunity to testify, and I would be happy to answer any questions.
Thank you very much, Dr. Begich, for your testimony. The chair now recognizes Ms. Leandra Ross for 5 minutes. Ms. Ross.
Good morning. I'm excited to be here and excited to be a part of this process. My name is Leandra Ross, and I'm the Vice President of Executive and Tribal Services at Southcentral Foundation. I'm a Tlingit and Haida Central Council and Salamatoff tribal member. I want to thank the committee for the opportunity to testify and for your work on behalf of tribes, tribal organizations, and Alaska Native and American Indian people. I also want to thank Alaska's Congressman Nick Begich for introducing this important legislation. SCF is the Alaska Native Tribal Health Organization under the Tribal Authority of Cook Inlet Region, designated by 11 federally recognized tribes to provide healthcare services to people eligible for IHS services in the Cook Inlet region. SCF is one of the largest employers in Alaska. With over 2,700 employees, we provide health services for physical, mental, emotional, and spiritual wellness of over 70,000 Alaska Native and American Indian people that live in the municipality of Anchorage, Matanuska, Susitna Borough, and over 55 Alaska Native villages. SCF's service area encompasses over 100,000 square miles, the area the size of some small states. SCF has over 80,000 patient encounters annually across our systems through 90-plus programs. SCF was established in 1982, and we're one of the first areas to compact with IHS and have been practicing self-determination for over 40 years. Today, I'm here to testify on HR 3620. This bill will transfer title to land that the Indian Health Service currently owns, on which the Southcentral Foundation operates our Keweenaw Clubhouse program. This land transfer is necessary for us to build a new 40,000 square foot building to house two critical programs. The buildings we are using now for the Keweenaw Clubhouse are some of the oldest in the IHS inventory and were never intended to provide direct services to clients. With the new building, we'll be able to expand our services to Anchorage's most vulnerable individuals that experience persistent mental illness and adults with complex behavioral health and substance use needs. A key component of SCF's plans is that we'll be able to co-locate our integrated care management program with the Keweenaw Clubhouse. In short, this new facility will house SCF's most intensive levels of behavioral health outpatient programming. The Keweenaw Clubhouse opened its doors in 1993 as an answer to the ongoing need for adult chronically mentally ill people. Keweenaw Clubhouse is a day treatment program that blends behavioral health and primary care services in one location, allowing us to meet our customer owners' individualized treatment goals. We currently have 120 customer owners who are provided with services on a regular basis and in most cases a daily basis. The success of this program is evidenced by the fact that all of our Keweenaw Clubhouse customer owners are housed in a city where over 40% of the homeless population in Alaska is Alaska Native. We're proud that the services we provide have enabled customer owners to overcome this hurdle despite suffering from persistent mental illness. We're particularly proud of the work we've done with our Alaska Native veterans. This program increases their level of independence and develops a community support network. Integrating these two programs into one building will facilitate the provision of both community and milieu-based programming. It will allow for expanded hours of operation, and it will allow us to double the number of customer owners these programs can support. The new building that we are planning will allow us to provide these services in a new facility rather than old buildings that were never intended to serve clients. Importantly, a new facility will allow us to provide services to more customer owners. We know the need for the services provided is more than double what we're currently able to provide today and with space constraints. HR 3620 will make this planned goal possible by Southcentral Foundation ownership over the land so that we're able to undertake all of the necessary responsibilities to build the building that we need to meet the needs of our customer owners. Again, thank you for the opportunity to testify and to tell you about one of our amazing programs and what we do every day. I've also brought with me 6 letters of support to be included in the record. Thank you, and I'm happy to answer any questions.
Thank you, Ms. Ross, for your testimony. Now I will recognize the gentleman from Michigan, Mr. Bergman, for 5 minutes to speak on his legislation. Mr. Bergman.
Thank you, Mr. Chairman, and thank all of you for being here. I know nobody's nervous because I've listened to your testimony and you've been very calm and collected, so thank you for your testimony. And I want to thank the subcommittee for including my bill, HR 411, the Keweenaw Bay Indian Community Land Claim Settlement Act, into today's hearing. HR 411 is a straightforward and long overdue bill that seeks to right a historic wrong against the Keweenaw Bay Indian community, or as we refer to it locally, KBIC. Under the 1842 and 1854 treaties of La Pointe, KBIC was guaranteed rights to certain reservation lands in Michigan's Upper Peninsula. But in the late 19th century and early 20th century, over 4,000 acres of those lands were improperly transferred to the state of Michigan by the federal government. These transfers were made without the tribe's consent, without compensation, and in violation of treaty rights that are still legally binding today. My bill is simple. It authorizes a $33.9 million settlement to resolve KBIC's land claims, an amount based on a professional appraisal and agreed upon by the tribe and the Department of the Interior. These settlement funds could be used for any lawful purpose except gaming, and in return, the tribe would agree to permanently relinquish its claims to the disputed lands. The bill does not seek to reclaim land from current non-tribal owners. Rather, it clears title for those who purchased the land in good faith, thereby removing decades of legal uncertainty. This is a balanced solution that honors our treaty commitments, compensates the tribe fairly, and provides certainty to local communities. KBIC President Robert Curtis Jr. is here before the subcommittee today, and I'm looking forward to his testimony on the bill. With that, I yield back.
The gentleman yields back. The chair will now recognize members for 5 minutes for questions, and we will start by recognizing the gentleman from Michigan, Mr. Bergman, for 5 minutes. Mr. Bergman.
Now, I guess I'm ready because Mr. Begich turned my microphone on. Is there anything that you would like the committee to know that you think has really not been clearly described in my words or in your words that would make a difference to the committee, or details, but in the good faith part, just the moving forward with long overdue compensation?
Really, I would just like to reiterate, that it is an historical wrong, and we want it just to be right, and we want to make sure that people have the clean titles in hand, that's it, it's been going on for a long, long time, and this is the closest we've ever been. We'd just like to keep moving forward.
Thank you. Mr. Chairman, this is brief. We have talked about this bill for a long time. There's been a lot of effort, both by the staff, by the KBIC, by our office, by the appraisers, everybody, to make this right. So it's, rather than waste words and time, let's just go ahead and get this bill in. Let's get it done. And I guess if I was to say where the KBIC is located physically, it's some of the most beautiful part of the Upper Peninsula, because we've got a lot of woods, a lot of beautiful fresh water, and a lot of great fish. So having said that, thank you for the time, and I yield back. Thank you, Mr. President, for your commitment to making all the I's dotted, the T's crossed as we pass this. Thank you for leading the KBIC.
The gentleman yields back. I want to apologize to our witnesses and the attendees here. We have some members that need to briefly attend another committee. So to accommodate those members' attendance at another committee, the chair declares the subcommittee in recess, subject to the call of the chair. The subcommittee will come to order. The chair notes the presence of a quorum. At this time, I will recognize the ranking member of the subcommittee, Congresswoman Ledger Fernandez, for 5 minutes. Congresswoman Ledger Fernandez.
Thank you, Mr. Chair, and thank you to our panelists for their grace and indulgence as we battle many, many different obligations here. Dr. Begich, thank you so very much for the work that you have done and that you continue to do advocating for this pipeline that we need. And your statement about doctors staying where they last trained is key. We find that all over, right? And especially as we work to increase the number of medical professionals in rural areas. So I wanted to have you discuss a little bit more about how what is being proposed under Representative Stansbury bill, you've already seen in action through the HEAL program. So share a little bit more about maybe some of the stories that aren't reflected in numbers, but that are reflected in experiences on the ground that you've seen.
Thank you for that question. I think what's really important is, like I said, national data does show that physicians or a nurse or any healthcare professional will usually stay in the area in which they were trained. And I think for healthcare professionals, especially physicians, when they're immersed in like an ITU site, they get to actually experience the culture of the community that they're serving. They can experience more of the hardships and the obstacles that patients face, and then also become a part of the solutions to what the community or the patients that come up with solutions. And one of the prime examples is 2 physicians who are internal medicine physicians in Gallup. They're not from the area, but they came with the knowledge of wanting to serve. And during COVID, they were the 2 individuals who really took the time to learn more about the culture of our community. And they were the ones who developed our hotel motel program, where individuals, when they were tested positive, because a lot of the homes were multi-generational homes, and some of our families didn't have running water. And so they were the ones who developed, they went out and they actually advocated for the city and the state to help set up one of the hotels in Gallup to take care of patients and have them being cared for. So, those are, like I said, I worked with a lot of dedicated individuals. And then one of the underside of not having enough, staffing is just really burnout of physicians.
Right.
And that sometimes they don't stay for the long term.
Right, thank you. And the IHS facilities and the tribally run facilities are there, right? We should use them to increase the supply of physicians and providers. Ms. Ross, we heard in the testimony from the administration that one of their concerns was, well, we don't know, there's no guarantees, we don't know what they're going to do in terms of health care that they're going to provide. I read your testimony. You guys have very specific plans. Like, you want to get to building, like, what you're going to do. What is your response to the concerns that were raised by the administration about, well, they say they're going to use healthcare, but it's not in writing. Give us a little bit of a sense of what you're going to do.
Thank you for the question. Southcentral Foundation has been in operation since 1982, providing services to Alaska Native and American Indian people. This property is zoned for the specific programs that we are operating. We've been operating this program since 1993. This is a community need in Anchorage, and we will continue to operate that. I think that our track record stands for itself.
Right.
Thank you.
So, and real quickly, with regards to the funding you receive, how much of the revenues do you estimate are actually from Medicaid?
For South Central Foundation overall, I would say that basically our budget is around 60 to 70% that is private payer, so, or third-party payer. So in that is Medicaid.
Okay, so it's somewhere around maybe 40 to 50%?
Exactly.
Thank you so very much, and thank you for your plans, and thank you to all of the witnesses. Mr. Curtis, I loved reading how collaborative and cooperative your proposals are, and thank you for the work that you're bringing as well, Chief Clerk. And with that, I yield back.
The gentlewoman yields back. I will now recognize myself for 5 minutes of questions, and I want to thank all of you for your patience as well, our witnesses, as well as the attendees here for letting us get to other committees and take care of businesses there as well. So thank you for your patience. Chief Cook, the legislation that we're talking about that you testified on today, HR 2916, introduced by Congresswoman Stefanik, would ratify the Akwesasne Mohawk land claim settlement. It's my understanding that all the parties involved in that settlement support the proposed end result. Is that correct?
Yes, all the parties involved in this settlement are fully supportive.
Can you talk for just a minute about what this settlement means for your tribe?
Well, it will give our neighboring towns and counties certainty, but it also will give the St. Regis Mohawk tribe certainty. And it will ensure the viability of the tribe in our homelands, allowing us to acquire additional lands for housing and economic development. And also inside of the agreement, it provides free education for our students if they attend SUNY schools in the state. And we need that education for, continued leadership in our community. Also, I alluded to the cooperation between ourselves and our neighbors rather than confrontation.
Wonderful. So this increases cooperation, economic development, self-determination, education, all those things.
Housing, right?
And housing.
Yeah.
Wonderful. President Curtis, thank you also for your testimony. The bill that we're talking about relating to your tribe provides a settlement of $33.9 million for the Keweenaw Bay Indian community. Can you talk a little bit about how the parties arrived at that $33.9 million figure?
Sure, sure. So we had, hold on here, please. I'm sorry. Oh my God, I can't see. Hold on here.
It's quite all right. I understand there might have been maybe two different, or an assessment that was done, or evaluation that was done, or two different valuations that were
Okay,
done.
here we go. I'm sorry, I've got it. So the tribe commissioned a report by Compass Lexicon, a firm that specializes in these sorts of valuations. And the report came up with a range of compensation, and the figure falls in the middle of that range. That's how we got that.
Okay, great. So in the middle of that range of assessments that have been provided then? Okay.
Correct.
And can you talk a little bit about what this settlement would mean to the Keweenaw Bay Indian community?
Sure. So the settlement is about righting an historical wrong. It is about our people finally being heard and seen and our rights upheld.
Okay.
Does that answer your question?
Yes, sir, it did. Thank you very much. With that, I'm going to yield the remainder of my time back. And at this time, I would like to recognize for 5 minutes the gentlewoman from New Mexico, Ms. Stansbury. Ms. Stansbury.
Thank you, Mr. Chairman, and I too want to say thank you to all of you for traveling, in some cases, all the way across the country and the continent to be here with us today. I want to say a special thank you to our tribal leaders for being here with us today, and also I actually am a graduate of Cornell's Native Studies program, so I want to do a Mohawk Haudenosaunee shout out because, of course, Akwesasne is very closely allied with the Native Studies program, and it's wonderful to have you here today. I also want to say, in my previous life, I worked on the budget at OMB for tribal affairs, and I had the amazing opportunity to visit Alaska and visit with many of our both tribal nations, Alaska Native villages, as well as many of the healthcare consortia in Alaska. And the work that these consortia and compact organizations are doing is like the most extraordinary integrative care in the country. It's the model. And in fact, I talk a lot to folks in New Mexico about it because it brings together, and we have a similar kind of setup in Albuquerque with First Nations healthcare, but the contracting and compacting of multiple tribal nations to provide healthcare, mental health services, and to serve multiple members of different communities is really impressive. So thank you for representing that. But Dr. Begich, we're here to talk about your work and the importance of pipelining more people to serve in Indian Health Service medical facilities as well as affiliated programs. And I have to admit, I even texted my staff that I cried a little bit when I heard the end of your testimony about your personal experience of shadowing a doctor on the Navajo Nation and how that showed you that you too could be a doctor. And so, I wonder if you could talk to us, tell us a little bit more just conceptually, why are these programs important? Why is it important for people that want to go into healthcare to see and be served by people who are from the communities? And how would a program like this that's institutionalized help overcome the barriers to getting back home to doing that work?
Thank you. That is a very important question. Programs like this that bring in the cultural component, that bring in the history of the populations that individuals, whether they be American Indian Alaska Native physician or a healthcare professional or a non-Native, it's really important to understand the historical context of our healthcare. We are very unique in the fact that we talk about social determinants of health. We talk about where somebody lives, where they were educated. But underlying for American Indians, Alaska Natives, we also have to consider political determinants of health, where a lot of our healthcare is based on upstream decisions that are made here at this level. And so, but we need to make sure that we advocate and we help to empower healthcare professionals not only to use their clinical skills that they obtain during their education, but then also we need to also teach them to be leaders and advocates within the communities that they're serving, whether they are non-Native or Native, but with having those programs or a residency that's funded by GME at an ITU site is going to be very important so that we can also teach them about historical facts of Indian healthcare.
Yeah, and I think on both sides of the equation, and you alluded to this in your testimony, that when healthcare practitioners, whether they're from a community or not, have the experience of being in a community where they experience the whole life of a community, they're more likely to stay there and serve. And there's also, I think, on the flip side, we know the data show us this, that health outcomes are better for everybody when they have healthcare practitioners who are invested in the community, who look like them, who speak the same languages as them. And certainly in the Navajo Nation, we have a lot of elders who their first language is Dene, not English. And so having healthcare professionals who speak the language is really important as well. And I wish I had hours more time, but I unfortunately do not. So Mr. Chairman, thank you so much. And again, thank you all for being here.
The gentlewoman yields. At this time, the chair recognizes the gentleman from Michigan, Mr. Wahlberg, for 5 minutes. Mr. Wahlberg.
Thank you, Mr. Chairman, and thanks to the panel for being here. Especially welcome one from beautiful Michigan and a beautiful part of Michigan. Michigan's home to 12 federally recognized tribes, which adds to our rich history. And I appreciate the subcommittee considering a bill today that would rectify a wrong done in the late 19th and early 20th centuries. And I applaud the tribe for their work with community members to garner wide support for the legislation we're considering today of Representative Bergman. President Curtis, welcome. It's good to see you here. The Constitution enshrines and protects certain property rights. The Fifth Amendment demands compensation when federal government seizes land. President Curtis, would you say that this land claim settlement fulfills both the United States constitutional duty to compensate landowners when their property is taken and its obligation to honor treaty-protected rights?
Yes,
So it's a good step.
yes.
It's a necessary step. If Congress doesn't enact H.R. 411, what recourse does the Keweenaw Bay Indian community have for its recourse?
Wait for the next administration? I don't know. I have no idea.
So virtually no recourse.
Could who knows? I honestly don't know. I'm sorry.
This is something that's been too long in coming. And really, Mr. Chairman, it gets down to the point that it is the only way of doing it. Correct, President Curtis?
Yes, correct.
Yeah. Well, thank you for making succinct statements. I wish we had.
Hope I didn't offend no one.
I wish we had more succinct statements. Because frankly, that's the only answer, and that was the one that I expected and one that I hoped as well, substantiating the need to move this forward. Thank you. Chief Cook, what steps remain to finalize the settlement?
We're waiting for the governor to name a date to sign the agreement. And we checked in this morning, and her lead man said that they're just waiting for the date for signature. And once that's done and this legislation is passed, then we just go on to the final step.
Well, as you know, the settlement outlines the ability of the tribe to acquire up to 14,000 additional acres. Is the tribe aware of any acres that will likely be acquired once this settlement is ratified?
Once it's ratified, there's 3,500 or more acres that will automatically come back. Those acres are already owned by Mohawk members. And
Individual members?
The tribe, yeah, individual members, and the tribe itself owns some parcels. In the 14,000, that would be by willing sale or transfer. And so that's yet to be seen.
Okay, but you would expect that there would be.
Yes, we're hoping that it would. Yeah.
Okay. Well, I appreciate that, and Mr. Chair, I yield back.
The gentleman yields. At this time, the chair recognizes the gentleman from Puerto Rico, Mr. Hernandez, for 5 minutes. Mr. Hernandez.
Thank you, Mr. Chairman. I want to reiterate my long-standing commitment to tribal sovereignty, both in the formal and functional sense, and my respect for tribal leaders as they fight to assert congressional respect for that sovereignty, autonomy, and self-governance. Ms. Ross, your testimony describes how the Keweenaw, and I'm sorry if I said that wrong, clubhouse blends behavioral health care with cultural connection and practical supports like housing and case management, all under tribal leadership. As we consider how to strengthen care in other underserved regions, do you see elements of your model that could be adapted to meet the unique cultural and structural challenges faced by other U.S. communities struggling with behavioral health access?
Thank you for the question. I'll be succinct and say yes. And we offer, through Southcentral Foundation, our NUCA model of care, a conference yearly for people to come and learn from our model and what lessons they can take away for their communities and what we've implemented in our innovative healthcare. So that conference happens every year, Solstice Week. Beautiful time to be in Alaska, June 23rd. So there is a number of people that come from all around the world, actually, to learn about our model and our takeaways.
I come from a Caribbean island, so I think June, July, and August are the only times that I could visit Alaska. I appreciate that, and since Ms. Stansbury had some further questions, I will yield the remainder of my time to her.
Thank you, Mr. Chairman.
Yes, without objection.
Okay. Mr. Chairman.
Before you yield, may I just make a suggestion that we all go up to Solstice Week? Could we look at that?
I like it.
Without objection, we will consider that, Ranking Member. Representative Stansbury, you are recognized.
Thank you, Mr. Chairman, and thank you, Mr. Hernandez. I wanted to ask a few more questions because I ran out of time during my question and answer about, and I'd love to ask both Dr. Begich and Ms. Ross, because you're both in the healthcare field. Again, tell us more about why it's so important that we pipeline more healthcare professionals to serve in Indigenous serving organizations and institutions, and how having dedicated funding at IHS will help to make that possible. Like, what changes when we have dedicated funding to do that? Starting with Dr. Begich.
The dedicated funding for the IHS expansion is really to development of a GME office, which would allow the collaboration with academic medical centers in the oversight of recruitment of medical students, as well as residents, as well as fellows from different specialty areas, and place them in areas in which in ITU sites so that they can learn about the communities, learn about Indian healthcare, because as I said before, this is a unique healthcare system, and so that would be very important.
And as a former Fed myself, one thing that people may not realize is like a doctor might not think of like, I'm graduating medical school, I'm going to go on USA Jobs and look at this empty or vacant healthcare program in Gallup. And so part of the mismatch is getting people pipeline from the healthcare field into the federal service. And that's why this model, which has been highly successful based on the VA, is really an important model, because that's how we get people to bridge that gap. Ms. Ross, would you like to also share some thoughts?
Oh, I think that, Alaska is a unique place to live. And I know that, part of it is the desire to live in Alaska and to come. And so we really appreciate all of the mechanisms that bring people to Alaska so that they can learn about how to serve and to experience it. And I think that once, when people come to Alaska in those capacities, often if you love it, and you stay. And so we're really happy for that. Thank you.
Thank you. And I know, President and Chief, you're not here to talk about healthcare, but do you have anything that you would like to add about the importance of getting more doctors into the IHS system?
I actually am a family nurse practitioner as well.
Well, there we go.
Yeah, and I worked at my clinic for 30 years prior to becoming tribal chief. But I was interested in the remarks that were made earlier in the questions about advanced appropriations and their absolute necessity in being able to recruit and retain medical staff.
Absolutely. Thank you. And I know we're out of time, but President?
No, I just agree that more help is needed and more funding is needed. That's it.
Thank you. And I'll just say this, Mr. Chairman, all four of these bills are completely bipartisan, and we're really grateful that you all are here. Thank you. I yield back.
Thank you very much. The gentlewoman yields back to Mr. Hernandez, whose time has expired. At this time, the chair recognizes the gentleman from Alaska, Mr. Begich, for 5 minutes. Mr. Begich.
Thank you very much, Mr. Chair. Ms. Ross, thank you for joining us again from Alaska and your leadership at Southcentral Foundation. As you noted, the facilities currently used for behavioral health services were never designed for that purpose. Some even converted from morgues. Can you explain how transferring the land in H.R. 3620 will unlock the ability to build a modern facility that meets the growing behavioral health needs of Alaska Natives in Anchorage?
Thank you for the question, Congressman Begich, and thank you for your strong advocacy and your comments earlier. I really appreciated that. This is one of the oldest buildings in IHS inventory, and one of the buildings that we currently use for our customer owners was the old morgue, and we've continued to invest in that property because it's in a location in an area that serves our customer owners. They like where it is. Our employees like where the program is. The community likes where it is. This is a piece of property that is zoned for this particular service. And so, as you know, some communities, when they see programs that are for people that experience persistent mental illness, they may not want that program there, but the community wants this program, and so that's really essential and has been supported. We have invested in this building and keeping it together. We have pictures that I'm sure we can share with the committee of the current building, but it really isn't to our standard. And, we would like to have title to the land so that we can invest in a 40,000 square foot property that's going to look like this. And so I just want to share that. And just to say, when you're going to build a property of this size, I appreciated the chair's comments on, well, you'd want to have title to that property. So, and that's exactly right. So this land conveyance, HR 3620, will give us that title so that we're able to make the investment into this service.
Thank you. Just to extend on that a little bit, could you share how co-locating this program with your intensive case management team under one roof will help enhance patient outcomes and reduce strain on emergency responders and hospitals?
Sure. So we have a number of employees that work in intensive case management, which is a program designed to meet customer owners where they're at in the community and provide and help them to resource the services that they need. It's not dependent on a location, and so, but some of the people and the customer owners that the ICM team works with might benefit from a day clubhouse program. And so it'll make kind of the handoff to the clubhouse program kind of seamless. And this is a program that in the community is necessary, and we've just seen great outcomes happen from the blending of the two together.
So it's about both effectiveness and efficiency for your customer owners and for the providers.
It is, yes.
That's great. From your perspective, what message would Congress send by passing H.R. 3620 in terms of supporting tribal self-determination and investing in effective Native-designed healthcare delivery systems that are saving lives in Alaska?
I think that this committee in Congress sends a message that they support a tribal health organization that cares for their customer owners, and so therefore cares for tribal citizens.
Thank you. And just a quick comment in my remaining time. My wife actually was a United States Public Health Service pharmacist and worked at ANMC for several years. And I can tell you through that experience, it became very clear how challenging it can be to find and retain high-quality employees throughout USPS, right, through United States Public Health Service, as it relates to IHS facilities in some of the most challenging operating environments. And I fully recognize how difficult that can be, depending on where these facilities are located throughout the country. And I think the efforts to ensure that we do have a strong pipeline should be strongly supported. And with that, I yield back.
Gentleman yields back. At this time, I want to thank all of our witnesses for your patience and grace with our brief recess, but more importantly, for the testimony that you gave this morning, and for my colleagues for your great questions. Members of the committee may have some additional questions for the witnesses, and we would ask that you respond to those in writing. Under Committee Rule 3, members of the committee must submit those questions to the committee clerk by 5 p.m. on Monday, June 16th, 2025. The hearing record will be held open for 10 business days for those purposes. If there is no further business, without objection, the committee stands adjourned.